There's a few apologies in the who's is.
Yeah, I can do that, David.
Please,
so
please.
we've got apologies from Russell, which obviously you're chairing today, David. Thank you. Apologies from Fiona Burton and Ellie's here. From governors, we've got Leslie McGuigan, Jim Sinnott, Jeremy Shearman, Matthew Gain, and Michael Coker has joined us. So we thought we might have his apologies, but he is here. Thank you. And just to note, it's Umar's first Council of Governors meeting today.
Okay. Umar, where are you? I can't see you on my screen.
I'm here.
Say hello to everybody.
Hello,
please.
everybody. Hi.
Yeah.
Good to be here.
And I was going to say, and tell them who you are as well, Umar, because that will be helpful for them.
Yes. So, hi everyone. My name's Umar Zaman. I was on the board at George Eliot Hospital as a non-executive director, and been lucky enough to be appointed as joint non-executive director on both the boards. So, looking forward to it.
Yeah. Welcome. Can I just confirm that we're quorate now? We are. Yeah.
Yeah.
Declarations of interest. Anybody got any declarations of interest? I'll say at this point that all the non-executive present have got a declaration of interest for item 9.6 because it specifically relates to our appointment. But I think Mike Flaxman is going to take control at that point. Just record that for us. Minutes of the last meeting. Any errors of fact? Please put up your hand if you want to correct anything. Can't see any hands, so I'll sign those as correct. Moving on, matters arising and actions update. I think they're complete, aren't they? All on the agenda. Sorry, I'm just going to move beyond my point on my agenda thing. Yeah. Anybody got any comments on the action log?
Yes, David, can I just add to
Please.
action? So the item on the stroke services, the government requested assurance item, there is an update on that. However, there's been further progress since. We understand a further full review of stroke pathway services has been commissioned, which is about to kick off, and which we've obviously asked to participate in. I understand the first meeting is the 5th of March. It's not clear how long that process will last for, but we will update following.
Thanks for that, Adam. And the last of the things in progress, I think it's on the agenda, is it not? I think I saw Jenny and you are talking very shortly on that, aren't you?
We are, yeah.
Anybody got any other matters arising? No. If we move on to my remarks, I think I've got 4 things I want to just highlight. One is the first joint board meeting of Swift and George Eliot actually took place on the 4th of February. If people remember, previously we were meeting as something called Boards in Common, but this was the first formal joint board. It went very well as far as from what I witnessed and everybody else, I think, and it really highlighted the huge amount of work that's gone on in the background since the joint executive took up their posts. I think it was November, wasn't it, last year? It seems like an age, but it hasn't been very long at all, has it? But a lot of work. All the senior executive and operational structures are in place, and I think work is now progressing on some of the other departments like nursing and informatics. So things are progressing really well, and given the timescale, remarkably well. The trust continues to have pretty extreme operational pressures, and since the last Council of Governors, we did have to declare a critical incident in the middle of January. Actually, this was caused not just because of high numbers of patients, but it was also the high severity of the illness of the people that were actually presenting, which it was almost like a perfect storm. It made it very difficult to safely manage the department. I have to say the teams were extremely effective in dealing with this, and the incident was lifted within 48 hours, which I think shows how much hard work our guys and girls do when these sort of situations arise. Another thing I want to Yeah. Another thing I want to inform Council of Governors, which I have to do, is that Swift has received something called a MOS Level 1 alert. This is a relatively new system that NHS England's implemented regarding maternity safety. And I'm going to have to read what it stands for: Maternity Outcomes Signal System, because I'd have never remembered if I hadn't written it down. Effectively, it's an early alert system when there's signs that something needs to be looked at, that there was potential safety issues in maternity in a trust. In our case, the trigger was because we had 3-term stillbirths in a pretty short period of time, not even 3 weeks. We've already, because there is a timescale attached to the actions with this, I can assure Council of Governors, those actions have all been implemented and are either completed or in progress, and that any learning that does come out of this will ensure that it gets implemented as soon as practical. I think it just highlights it's a really good system. It's only new and we haven't yet seen the full potential of it, but I think it ensures the trusts can't ignore potential safety incidents. I'm not suggesting we would ever have done that, but actually I think this is a national thing. So I'll perhaps update people on the outcome of that, or my successors will do, later in the year. The final thing is, of course, this would have been Russell's last Council of Governors as chair of the trust, and he really was hoping to be here, but he's had an offer that he couldn't refuse to visit London. And nothing to do with Swift, I might add, but he's had to go. Hence, you've got me chairing the meeting. He did contact me this morning, and he said he wanted me to convey his extreme thanks to the Council of Governors for all the support they've given him over the previous 10 years, and I think he really meant that. So I think if we can make sure that's formally noted, and that'd be helpful. I've got nothing else to say, but anybody got any particular questions about what I've just said? Please raise a hand. I see none. No. So can we move on then to assurance item, the EPR implementation update. Robin, are you around?
Yes, I am.
Yep.
I'm here.
Over to
Thanks,
you.
David. Thank you. I'll do a brief introduction, and I know Alan has got a couple of slides to share. So thank you for the invite to come and talk to you today to give you an update on the EPR implementation. It's fair to say that in discussion with over 20 trusts across the country now that we've spoken to that have gone live with EPRs, they're extremely complex programs, and there's a lot of challenges on the journey. So it's not to be it's not unexpected that we meet challenges along the way, but it's how we cope with those challenges. And there's a really robust process in place, and a robust governance structure in place in order to manage those challenges. And critically, I tried to sort of shorten them into 3 core pillars, really. One's the financial challenge, one's the operational and patient safety deliverability challenge, and the other is the technical deliverability of the system. And I know that first, thank you to any of the governors that sent questions through, and we've tried to incorporate responses within the slide deck, but obviously David, I'm happy to take questions at the end of the slides where people feel that some of those haven't been covered. So if I may hand over to Alan to talk us through the slide deck.
Yeah, thanks, Robin. I know we've got Paul Shoes-Webb on the call as well, and there is a slide on productivity that we'll probably get Paul to talk to, because he's taking the lead on that for the programme. So I'll quickly share the slides. Yeah, only a couple, so it's not death by PowerPoint. And what we've tried to do is pick up on high level some of the questions that we've already responded to in I think some email responses that we've put back. And there's 2 themes really in the questions that came out that we've responded to in detail. One was around kind of the EPR system sort of resilience, and during the program and post go live, and then the second was around productivity. So I'm going to cover off a little bit on the sort of EPR system resilience, what's in place within the program, what will happen at go live, etc., to provide some assurance in this space. And then, like I say, I'll pass to Paul on productivity. So I guess there's a number of areas where sort of EPR system resilience is at play, really. And I think the first one really important on that first slide is kind of the supplier's disaster recovery plan. So Oracle Health have a disaster recovery plan that we have signed up to, part of the contract. Some of the headlines from that plan, I guess, worth just calling out are data centres, 2 data centres, one that hosts the live system that we will access, one that hosts sort of the test and training environment. So they're separate data centres, separate physical locations. And that second data centre also has that copy of the backup. So you've kind of got that physical separation of the data centres and the servers and the backups in case of a disaster. So that's a really important point from an Oracle point of view. Second thing you've got going into those data centres from both Swift and George Eliot are dedicated network connections. So there'll be 4 network connections provided by different carriers. So your Virgins of the world and your BT Openreach, it's not all through the same supplier. So you get some resilience there. If one carrier has a problem with the network connection, you've got a second carrier in place, and there's 4 connections with failover. So you've got some resilience there in terms of how we access the data centers. And then the third big point coming out of kind of Oracle's disaster recovery plan is the what's called the 24/7 access downtime viewer. Well, I call it 24/7, they call it 7/24, but I think that's kind of come from America. So 24/7, what that means is there will be, through the 2 hospitals, there will be dedicated computers that are taking a copy of some of the clinical PAS data, that in the event of a downtime and access to the main system, you can access in an offline format this key clinical ops data, print it out, use it in a business continuity setting. So it's always worth reminding people it's not a full set of the clinical data, but it's a subset that's used in sort of business continuity purposes. So that's kind of the bedrock to the next bit that we're going to talk about, which is business continuity, which obviously is a responsibility of the trusts. So we align all our BC plans to that disaster recovery plan, and also the Innovate disaster recovery plans that are in place. And underway on the programme, just about to start, is kind of a service by service review of existing business continuity plans and how bringing the EPR is going to change and impact those. We've got an operational readiness group about to stand up in March, chaired by Harkham Al-Dakou, that will provide oversight to many areas to make sure that both trusts are ready to go live from an ops point of view. And part of that will be BCP, so the business continuity. And then a really sort of important point around BCP, because this is a single instance with Coventry, so it's going to cover the sort of Coventry and Warwickshire, the 3 big trusts. We've started high-level conversations, kind of a system-wide ICS sort of BCP planning, and that will be incorporated into the programme as part of our work over the next 9 months. So we need to go a step further than just that trust BCP, but cover it across the region as well. And that will be an important part of our sort of sign-off to go live, that we have those regional BCP plans in place. Couple of other points around this, I guess. Cyber security, this was referenced in some of the response we came back with, not just EPR, obviously, cyber security relevant to all of the trust digital systems and all of us in our lives. There's been a lot of strengthened measures across Innovate around cyber security. Big piece of work around that malware avoidance, so that you stop the emails coming in, stop the scams coming in, and rely less on the users to not click on the links and accept things they shouldn't. It's never 100%, so we'll always back that up with that comms piece, regular comms piece around it with both trusts and Innovate, to make sure we're reminding people of the importance of that. but a lot of work in the background to strengthen our measures on cyber security. And then I guess the final bit around sort of system resilience is obviously the data that goes in terms of migrating data from our existing legacy systems now. So we're taking data from Lorenzo, and that will move into the Oracle platform from both George Eliot and Swift. So we've got a big data migration work stream running. We're actually right in the middle of our first trial load of data. We're on week 3 now, where data is coming in from those legacy systems into the Oracle platform for testing purposes, and there are 2 more cycles through the program for trial load testing to make sure the data comes in, goes into the right place, is usable and accessible at go live. And linked to that is obviously data quality. So we've got a lot of data quality reports up and running now to monitor data quality as we go live and beyond. So obviously we put the data in from a migration point of view, but then we're going to rely on that data to be inputted by end users, and we've got to make sure we monitor and keep an eye on that data quality. So there's a lot of work around that space underway. And I guess the final point on this is that we have got a experienced data migration partner, a company called Cloud21, supporting this work. As you can imagine, it's a very complex piece to migrate data from 2 legacy trust systems into a live EPR instance with UHCW already live. So it's a very complex work stream. So we're doing this alongside a data migration partner who bring that experience, and they were the same partner used at UHCW. So I pause there. There's a lot we responded to in the emails around system resilience, but I will just pause there, and I think I'm handing over to Paul for a little bit on productivity, the risk and how we're managing it.
Thanks, Alan. So I know there was some concerns about productivity. So first thing to say is productivity will fall. It's almost inevitable when you roll out an EPR, there will be some decline in productivity. And I think the real key to this is having this as a planned recovery of productivity rather than an assurance that you'll not see any productivity changes. So we've been in early discussions with KPMG and NHS England, who only today have released their data for 17 trust study, which was both acute and non-acute trusts, to look at lessons learned from productivity declines. And the majority of productivity declines come in the elective pathways, the non-urgent pathways. The urgent pathways tend to show a fairly rapid resolution of their pathways because they are often slightly more simplistic, whereas the elective and the admission pathways can be slightly more complex in terms of admissions and those pathways. So what we're planning at the moment is trying to work through what our recovery will be to ensure that we can either front load some of this work so that there hopefully won't be as much of an impact on treatment times, and then have a recovery plan for those individual departments. The recovery plans vary from specialty to specialty because there's a nuance within it. But the aim would be to have a planned recovery at sort of 1 or 2 weeks. You'd be up to 80% of where you were before, and then going up to hopefully back to full recovery within a month or so, depending on specialty. And that's really the plans going forward. I'm relieved that the discussions that I've had so far with NHS England and with KPMG and with our workshop that we've had with NHS digital colleagues, there's nothing there that we aren't trying to achieve and that we aren't already trying to engage with. My CNIO colleagues at both George Eliot and Swift are already well underway with their digital literacy assessments to try and ensure our workforce has the required skills to start utilising the EPR. And one of the really important things is to ensure that we're looking into other technologies that can also assist us going alongside it, so we're not putting all our energy into EPR. And one of the things we're doing at the moment is trialing some ambient voice technology, which you may have all heard about. You may have seen it in general practice. So we're trialing that so that we can understand the proof of concept, so that if funding becomes available, we're ready to move swiftly with that to ensure that helps both our colleagues and our patients. more than happy to take any questions regarding the clinical aspect or the governance aspect on those points.
That's all three. I mean, before we go into the questions of the governors, I think I need to assure the governors that board has significant oversight of this project, and indeed audit committee is also got significant oversight of the project. So it isn't just people that are presenting that are involved. David Fitzpatrick.
Hi, thanks for the update on productivity. I think I would probably feel more assured if I understood a bit more about the lessons that had been learned. That would be, a good assurance factor. And I'm guessing all of that KPMG or Coventry and Warwickshire experience is being looked at. The second thing was, I think you've pretty well gone through the things that I asked questions about, but now that it's clear there's a 1 month impact period, you're going to create a backlog. So the follow-up would be, how are you going to deal with that backlog and its clearance as quickly as possible thereafter?
Who wants to answer that one?
So,
Go on. I'll leave Paul. You answer it.
yeah, I'm happy to take the productivity growth. So if you look at the data, certainly acute trusts, over 2/3 of them have a 50% decline relative to their peers in initial productivity, and in to be perfectly honest, there will be some long-term permanent differences in productivity in certain spaces, because there are certain things that require a very quick look and signature versus multiple clicks within the system. It's more really to try and work out how those workflows can change and what that. So you might see a productivity decline in a clinic, for example, but a productivity gain downstream from that clinic. A prime example would be pre-op. You might see a productivity decline in some of that because at the moment it's a very simple paper form, but those gains will be seen within the admitting teams, within the anaesthetist on the day, and within the post-op follow-up of those patients. Now that's quite difficult to capture, but those are where they're seeing those changes in how those clinics function. There are some clinics that can be a little bit more challenging in outpatients, and that's where they do see some of that productivity challenge within outpatients, and that's where we're looking at other products such as ambient voice technology. That's one of the things that the study of the 17 acute trust does recommend, is looking at those additional technologies to ensure that those are utilized as and when available. With EPRs, there's always a degree of pain that you have to go through with initially, but with the long-term benefits being the long-term single point of truth and the ability to access that for both patients and with staff, and in particular with the patient portal and that utilization, that's a huge benefit for patients and for them to be able to take control of their own health. So there's various things that I'm more than happy to chat with outside about what the learning points are with the learning points from those studies from KPMG and NHS England.
Okay. I'll allow you to come back in a bit, David. Let's get some more questions, see if there's any other things. Jean.
It's a really simple, basic question. Will the progress of a patient who moves between trusts and hospitals and areas, geographical areas, will it be seamless? And how soon will it be seamless? And we have funny little ones like opticians that the trusts are actually paying for, etc., etc. Will it be seamless?
I think that's a difficult question for anybody to ask, actually, Jean, at the moment. But I think that would be the intention, I'm sure. But
yeah.
If David, maybe if I could just come in on that. If I don't, it won't be. At the point of go live, it won't be seamless across the whole healthcare economy.
Yeah.
It will be. We will get a more seamless transition of patients that come in between the acute organisation, so between George Eliot, Swift, and UHCW.
Yeah.
and that's the huge benefit of us all being on a single instance, because effectively it is the same system. So that will be much improved, but outside of that, it will take time, obviously, to make all those other connections.
But you think that one day it will actually be achieved?
We hope
And
that's got to be the goal, but that's going to take some time.
That's great. That's all I wanted to really know. Yeah,
Just
I feel reassured.
just for clarity, pretty much from go live, we'll see everything everywhere. So we will see in stuff that has been performed at George Eliot and at UHCW on our system. So that's the huge benefit. There are challenges with whether you can order things elsewhere, which will be the long-term plan, but that will require a lot more work. The functionality is there, but it's more the fact that we're all sovereign organisations with the ability to do it. But the functionality of the system will assist in that.
And what about ambulances?
So they will not have access to the EPR on the current, and there are different parts. So community is different to our acute EPR. So it's not a region-wide single electronic patient record. Yeah.
Thank you.
Okay, Kelly.
Oops. Yeah, thank you. Just a couple of questions. I just wanted to know how long it takes to train clinical and non-clinical staff across the trust, when the training will be completed, and obviously I do understand, depending on their job roles, they will have different access rights to the system and all that sort of thing. So that's one. Training is one of my questions. If people, if they get stuck whilst at work, what sort of support they're going to have? And my last question is, obviously they're not involved at all. The local mental health trust obviously must have a different system, I assume. So they're on a different system. That's all. Thank you. That's all.
I'm happy to pick up the training question.
Please, Alan.
We've funny enough, it linked to that comments about learning lessons from UHCW, and if you talk to UHCW, they got the numbers through training, but they don't think they quite got the quality right and the content of the training right. So we're doing a lot in this space, and we're going to have a sort of a blended approach to the what we're calling the learning journey. So it isn't all at the end of the program and just before go live. It starts a lot earlier, and there's going to be a lot of things in this space. So there'll be the traditional classroom-based training for certain staff groups and staff that require that approach to training, and that's your normal sort of half-day, one-day type approach. But alongside that, and probably our preferred method for training, is going to be to utilise technology in a number of ways. We've purchased a gamification training solution called Attensi, which gamifies that training delivery aspect, which when you look at in the industry, it's seen as a real game changer for embedding knowledge in people and getting people understanding the way the system works and the impact on their job role. So and that will be obviously something that people can run in their own time at a time to suit them. So we'll have that, we'll have e-learning, but also starting very soon, I know at Swift there's an EPR hub and a drop-in centre where there's going to be the ability for sort of show and tell sessions via the clinical teams. So a really blended approach to training. So it's difficult to answer how long is it going to take, because it will depend on the delivery method that people use. But I think the key point is a very blended approach that suits different staff groups and different people in the way that they want to learn, and not just kind of 8 to 10 weeks before go live, which is when you do the chunk of your training, but actually start the journey to train people much earlier and start to sort of get it embedded in people across the organisations in terms of the EPR. So that's a big lesson from UHCW, and a big thing that will benefit that productivity plan, as well as we embed the knowledge in the staff around the EPR and how it impacts their day-to-day job role.
Thanks for that, Alan. David, you want to come back?
Yeah, thanks, Alan. I'm happy if there's not time to take that offline. But the question on productivity, I don't think it was answered. the ambient technology, all those things, great stuff. The lessons learned, I look forward to hearing what you've learned. But the point is, if you have a 2-week period of drop in productivity and a 4-week drop in productivity for some more complex areas, there will be a backlog of patients who will have not be treated where you normally would have. And my question is, how are you going to catch that up? To me, it's you've got to invest to catch up if you wish to.
Paul, you want to answer
Yeah,
that?
there will be a productivity drop. That there will. I can't say, you know, no one has managed to achieve this.
I understand there'll be a drop, but it's bolted in. It's how do you catch up? Say 400 people who didn't get treated that would have normally.
Yeah, and that's, you know, that is a question on how all of these EPRs and manage to achieve this, because, you know, this is where the study is trying to see how, you know, what can you do to try and minimize that. So that's the one thing that we can do as the EPR team. We can try and minimize this, make it as good and as successful as possible, and then we need to work out how the trust and how we as a trust then respond to that for our patients. So what we can do as the EPR team is try and minimize this and make it as seamless for our colleagues and our patients, and then we need to respond as a trust on how we recover from that, in the same way as we've had to recover from, you know, overwhelming admissions, doctor strikes, etc., etc.
Maybe one for Adam, who's next.
Yeah, Adam's going to be next anyway. Go on, Adam.
I was going to cover that point. So there's a few things I'd say here. I'll take the productivity point first of all, but I want to make a more general point as well. So productivity ups and downs happen all the time, and Paul just referenced some of them. We have doctor strikes, we have bits of equipment that fails, we have environmental issues in theatres where we lose a theatre for a week. We've got a team that are really good at managing that, and we manage that in a number of ways. What makes this really unique is we have a year of planning to get it right. So we will manage our electives in a different way. We'll do more in the run-up, we'll do more following, we'll have different kinds of case mixes that mean the productivity won't be hit as much. And we have a group led by the COO and supported by Robin and the EPR team to manage that. So yes, there'll absolutely be a productivity loss, but there are processes in place to support that, and it's what we're good at. I just want to make a more general point though. We're here answering questions that have been asked in advance about the EPR, and that's absolutely right. But I'm worried that we're erring on the very negative side of what an EPR is and what an EPR does. And I just want to make the point that in EPR, for this organisation, or for these organisations across Coventry and Warwickshire, is revolutionary in terms of patient safety, in terms of making sure we've got the information at staff members' fingertips, making sure that can flow between the three acute organisations, driving productivity in different ways, allowing us to do things that we can't do at the moment, making sure all of our staff have the relevant information at their fingertips. So I know you probably all know that already, but for the record, I just want to make it absolutely clear why we're doing this and what the benefit is for our staff and patients.
Yeah, good, well said. Mike, then I'll give the last word to Robin, as he's the senior responsible officer for this.
Thanks, David. It's clear to me that lots of people are working very hard to make this happen well. I trust our operational team to deliver services to the best of their ability, because they're fantastic. I think that's amazing. I did, funnily enough, look at Cerner for the UK in about 1992 to see if we could bring it over, but AT&T said they couldn't afford it, which was a bit of a shame, because I think it's a good system. All I'd ask is that we now have this as a regular item on the Council of Governors agenda for assurance and progress reports. I think it's very important that we are kept in touch with the principles, not necessarily the technical details, which I know David will understand, but most of us probably won't. But we just need a regular report at each Council of Governors meeting, or between if anything goes wrong, to be honest. I don't sense anything is going to go wrong. I think we're just going to all try very hard to make it work. And thanks very much for the presenting team. for coming along and suffering our questions.
Yeah. So last word from you, Robin. Let me move on.
Yeah, no, absolutely, Mike. We can do that. We can provide an update, and I can pick up with David outside of here how you want that update to come back. That's not a problem. The thing I was going to build on was Adam's positivity for EPRs. It is going to be a significant groundbreaking change for both organisations. It is going to be better for our patients. It's going to be better for our clinicians and better for our staff. Paul and I have just been in an hour-long meeting with Oracle colleagues where they've been demonstrating to us the next phase of the systems, which is won't surprise anyone to know is AI based, but the functionality of the next stage of the system is significant and will make significant benefits further. Our business case 5 years ago was predicated on significant multi-million-pound benefits to the organisation, and we're just doing a piece of work at the moment. I'm leading on that to go back to those original benefits and to look at how we are on track or not to realise those benefits, and if not, what we're doing to replace them or to put them back on track. And that's a vital piece of work underpinning all of it as well. But it's a really important and groundbreaking development for the organisations that will benefit all. So obviously we'll remain positive, but keep you updated as it's, as I say, complex and detailed, but we will keep pressing forward.
Thank you for that, Robin. We'll move on at this point. Adam, operational.
Thank you very much. So I want to talk a bit about our patient public voice strategy. We've got Jenny here who's actually doing the hard work. I'm just introducing. So firstly, an apology, because we've talked about patient and public voice for a long time, and we haven't got a document that describes our plans or our framework for this yet, and I'll talk a bit about the reasons for that in a moment. But I want to talk to you firstly about that. Jenny's going to talk a bit about why we think that doesn't really matter so much, because we're already doing some really good stuff on this. But then we want to talk about the work we're doing to get us in a good place for the future, and most importantly of all, get your input into some of that, because actually the work you already do in terms of patient and public engagement on our behalf is incredibly useful and supportive for us. So just get my slides shared. Hopefully you can see those. Okay.
Yeah.
So, firstly, a bit about where we're at in terms of the environment and why this has taken us longer to get a document than we would have liked. So, a few things have happened this year. It's been a year of significant change for us. So, as you're aware, we've brought our leadership structures together across Swift and George Eliot, and we're now operating in a position where we are lead provider for Warwickshire. And I think it's really important that we are looking at patient voice across Warwickshire, and building in some of the good work that's already been done in George Eliot and at North Warwickshire, recognising the services we provide are already cross-county through our out-of-hospital services, but also that in that role that's coming for us as lead provider, we need to engage and work with our communities in a really substantially different way. As our aspiration to be holder of an IHO contract, we'll be engaging about the commissioning services beyond what we traditionally provide. And I think that will require a very different type of engagement with our patients and with the public. We've also seen the publication of the 10-year plan. And this is quite a fundamental change, I think, when we're looking forward to what's different. So the role of an Advanced Foundation Trust, and we hope to be in the first wave of Advanced Foundation Trusts, will really make us think differently about what mechanisms we use to engage. And we also know the changes to Healthwatch are unclear. There may be a different role there we need to pick up. Healthwatch does some really good stuff for us at the moment. And when we talk in a minute about some of the things we've done, you'll see the role Healthwatch has played in helping us engage with our communities. We may have a gap there to fill. It's not clear yet. I'm really keen that I don't want to set a strategy or a framework that we have to change in a few months' time because the world is changing around us. And finally, there are changes to the CQC, and particularly a framework for addressing health inequalities through engagement with people and communities. And it's absolutely essential that that is built into our future. Now, there's never going to be a right time, but it feels like there's so many pieces up in the air at the moment that we need to be really careful about how we move forward. Having said all that, I think we're already doing some great stuff and we've already got some great processes in place. And if I hand over to Jenny, she'll talk about some of the good work we're doing.
Thanks, Adam. So good afternoon, everyone. For those of you who haven't met, my name's Jenny Bannon. I'm the Deputy Chief Strategy Officer here at Swift. So as Adam said, we think we've got some great examples of how we use staff, patient and public voice well. I've highlighted a few on these slides, which we'll share with everybody afterwards, but I'll just run through them now. So the piece of work Adam referred to that Healthwatch, we commissioned Healthwatch to do for us with regards to the development of integrated neighbourhood teams, which falls under Swift's responsibility as convener in the Community Integrated Contract. So Healthwatch did a great piece of work with us where they engaged with the public across Warwickshire, really to ensure that we were capturing that lived experience in how we were designing the footprints specifically for those neighbourhood services. We used those in 3 place-based workshops we had towards the end of the last year to co-design those footprints. Community Recovery Service, I think you probably would have heard about before, a service that we're really proud of. And when we sort of redesigned the service and initiated it, we used patient, provider and staff feedback continuously in the development of that service through from the pilot stages into the business as usual pathway that we have today. And that reference group still exists for that service. And particularly, we see that as an opportunity to bring our providers together to discuss the issues that they're seeing and share best practice and opportunities for improvement continuously for that service. The perinatal pelvic health service pathway, so it's a piece of work that we've done on behalf of the Coventry and Warwickshire system, we've led out as Swift. And this is a really excellent example of how we use co-production and using public and staff experience to inform the entire pathway development there, from kind of doing the gap analysis right at the beginning through to implementing the solution and really making sure we've constantly got the patient at the centre of that journey. Next slide, please. Just a few more that I wanted to bring out. So you may have seen this one in the media, the Young Inspectors Programme. So we've worked in collaboration with the County Council, Healthwatch, Youth Forums and the Sen Youth Forum in developing a framework that we're now using to drive improvements on the McGregor ward, our paediatrics ward, to make the ward more welcoming and inclusive for children and young people, which has been a really exciting initiative to be part of. And we're really looking forward to continuing to drive improvements in that area. And finally, just to sort of resonate what Adam said, we know we've got some really excellent mechanisms across the trust to hear the voice of the patient and stakeholders and our staff, and to really act on that organisational knowledge that we have in order to drive those improvements. And I've just listed a few of those there.
Anybody got any questions of Jenny in particular, since she's...
Well, I've got the mic. I'll ask you all a question first while you have a think. So we're really keen just to hear from yourselves really in terms of what you see as our opportunities to improve our approach to engaging our staff and patients and the public really. And once we've done that, I'll perhaps just wrap up with what our next steps are in this area.
Yeah. Mike.
Thanks, David. Most of the people on the call will know me that I've been harping on about the lack of an engagement strategy for about 3 years now, but still waiting for it. In my view, a patient and public engagement strategy document Doesn't need to be a long document. There are some key principles about how you engage with people, and setting that out in a document, I mean, I don't think takes very long, frankly. And I think we need to see something from the trust to say how in the future they intend to engage with patients and the public. There's obviously a lot of good work going on, and it's not that detail that you need, it's the principles that you're going to follow when you engage. I did actually send Adam the Health Watch charter on patient and public engagement this morning. He may not have caught up with his emails, but Health Watch produced a charter for good engagement in 2014 when we first started, and updated it again in 2019 by the addition of another line on it, basically. And those basic principles of patient and public engagement is what I would expect to see in the trust strategy, supported by a lot of the detail work you're already doing. So, I mean, I'll say no more. I've harped on about it more than enough in the past. We shall see.
Jenny, any comment?
Well, do you want to just pop the last slide back up, Adam? Because I think that kind of ties quite nicely into what Mike was saying in terms of our next steps, and then I'm happy to take any more perspectives or questions. So hopefully we'll all be pleased to hear that our intention is to co-produce a framework, which obviously we will take through further engagement and approval, but we are in the process of setting up a working group with staff across both trusts, both Swifts and George Eliot, our Warwickshire County Council joint roles as well in commissioning public health. There's some really excellent examples, both from Health Watch and from our partners across the system in terms of how this is done. So we're really keen to learn from those. So the framework in some respects is the easy bit. What we then want to do is do a gap analysis against that and produce a delivery plan, really to kind of target what we think our development areas are against our current needs and also some of those future ambitions that Adam set out. And really just to continue to work with all of our partners across the system to further develop our co-production mechanisms. We're involved in a really exciting piece of work that what was the Coventry and Warwickshire ICB have commissioned with Warwick Business School called Project Concord to look at what a co-production framework that's very specific for our geography might look like going forwards. So we're a little bit ahead of the curve here in terms of what we're doing in Swift in terms of where that work is, but we'll continue to make sure that interconnectivity is there so that we learn from each other. But those are our sort of our shorter term intentions there. And obviously the work that we do, we will be bringing back to yourselves and all of those forums that I talked about earlier for further engagement.
Mike, you want to come back on that?
Yeah, I don't want to see us get mixed up in complicated co-production processes with lots of committees. I mean, this isn't something you need to design by committee. The basic principles of engagement are fairly straightforward. You know, I just think we should write them down. Just my view, rather than going into lots of complicated co-production meetings with lots of other people. I mean, come on.
Adam, do you want to?
Yeah, so I think you're right, Mike. The principles are straightforward, and we could all say what the principles are now. But what I'm really keen we do is not just say principles, that they're structurally embedded into our organisation, and that we really are doing them. We're really living and breathing them. We're really making sure we've got the right mechanisms in place. That's the harder bit, and I want to do the two alongside each other, and I want to make sure that's built into our role as a lead provider as well.
Okay.
I led on health inequalities in Coventry for 10 years. We were awarded Marmot status. I don't know what young people or older people feel about this, that or the other, and why they're not engaging, and why it isn't until really late before they present at hospital, when by then, you know, it's a bit late. I really want to see everybody engaging in it, whether you're discharging a patient from a ward. When I was a ward sister, I used to make sure that they knew what had happened, and I used to go around the ward and talk to lorry drivers and, you know, whoever, and get feedback and engage them. And I think we're very not exactly middle class, but we're very, we think we've got a clear idea. When in fact, when did we last go in a mosque or a gatwa? Or, when did we engage at the times that we need to engage in order to make a difference? It's the make a difference bit that I'm really keen on. And we're in such a powerful position, being a trust and engaging with so many different people at different times in their lives, that I just think it's a wonderful opportunity. And I know Mike has got, loads of experience. So it's something I really, really care about, whether it be men's health or babies that die, everything, really. Whether you come from a different country and don't speak English and don't know what you're talking about when we present it. Yes, sorry. It's just something I'm really passionate about.
Don't apologise, Jean. You're making very important points. And I saw Jenny was writing little notes down, so she's obviously taking note of what you're saying, which is even more important, isn't it? Do you want to have a last word, Jenny, on this?
No, just to say thank you really for your feedback, and we will bring something back shortly. But I appreciate your time today to hear us talk about it.
Thank you. We'll move on then. Operational assurance. I think, Adam, that's got your name on my sheet. It
does, and I'm just in the interest of time, David. I'm not going to go through this in a huge amount of detail. Bear with me, just getting my papers back. So the documents include our progress against the objectives for quarter 3. So this is obviously the quarter that ended in December. Usual caveats. This goes up to December, and work has continued on these since. I think the only one that is red, which will come as no surprise, is the progress of the EPR work. And we've spoken about some of the complexities and reasons for that. And you'll see the actions associated with the work there. I think actually it's fair to say in quarter 4 that's moved away from red, and we're probably in an amber position now. And that is on the basis of some of the things you've heard today.
Okay. Anybody got any questions of Adam? Mike.
Oh, sorry, me again. Objective 17. The integrated neighbourhood teams issue. There was a meeting yesterday, quite a large one, for the Stratford cluster, which is quite a big urban operation. I haven't seen the presentation slides from it yet, but I'm promised them shortly. I don't sense governors really have any great understanding of what the plans are and how they'll be implemented. I mean, integrated neighbourhood teams, will they be virtual teams operating on an electronic basis, so they go out and see people? Will they operate from a site and provide services from them? I don't have any perception of what's planned, so I just wonder if we could have a report on it for the next meeting. That's all.
I think that's a really good call, Mike. I wonder if we could do a session on INTs at the round table next month.
I shan't be there.
Oh, okay. All right.
Apologies.
Well, we could perhaps record it, so you could
send me the presentation.
I mean, I think what I would say though is we're in really early days for integrated neighbourhood teams, to the point that the national guidance on what an integrated neighbourhood team hasn't been published yet and is expected really soon. What we have done in our role as convener is worked with primary care to establish what the footprints of the integrated neighbourhood teams are. The next step is about how they work, and just at a very high level, an integrated neighbourhood team is about a collaboration between providers to provide relevant local services to neighbourhoods or geographic areas within Warwickshire, and they will how those are implemented will vary depending on the area and depending on the priorities. A lot of that is based on data, needs, inequalities, and so forth. But we could talk through all of that at a session, either at the roundtable or at some other point.
Okay.
Thanks. That would be really helpful, actually. Yeah, I get the sense that we've been here before with care navigators and all sorts of other things in the past, and they've all died to death in the end. And I just wonder where it's going.
Kelly.
Yeah, thanks, David. Just that's objective number 11 about climate adaptation plan. On the update, there is something, all right, sustainability manager approaching or dealing with finance due to the risk of non-compliance based on climate-related financial disclosures. What that means, more or less. Climate-related.
That's a very specific question, Callie, and I might have to get an expert to answer and respond to you separately.
Yes.
Okay, I'll send an email then, and someone.
You do that, Callie, and somebody that knows what they're on about will get back to you.
Thank you.
Yes, it shows a very wise man who admits that he doesn't know things. Actually, when he doesn't know things. So well done, Adam. Thank you for that. Shall we move on? Ellie, patient experience assurance report.
Thank you, David. I'm going to take it essentially as read, but just really want to highlight the fact this is a joint report. So moving forward, we were looking at our patient experience metrics together as George Eliot and Swift. And it's really interesting to see some of the commonalities and similarities, and therefore the potential for learning and sharing best practice. And we're going to also look at some of our processes and procedures and share those as well. So there's potential there for helping with resource and, as I say, where we've got benefits, where we've got special roles in volunteering and things, we can share those across. So I'm happy to take any questions on the report. It's for the previous quarter, so some things may have moved on, but if anyone's got any questions.
Yeah, David Fitzpatrick.
It's not a question. I just wanted to acknowledge that I chased down this area with David and actually Ellie in terms of things like harms, and being very pleased with the assurance that I got, but also the evidence of all of the learning that the trust has been implementing around those things. So David, just we like Adam with the EPR, it's good. Yeah. I wanted to acknowledge this area is good.
Thank you, David. I always like people to say we've done a reasonable job. Adam.
Thank you for that, David. I just want to acknowledge in this report the support receiving from George Eliot on this, as Ellie's said. I think a lot is often made about how we support George Eliot and how the joint leadership team has led to improvements at George Eliot. But this is a really good example of where we've learned from George Eliot. They did some really good stuff in this area. They're quite well resourced in this area, and that has led to improvements here at Swift. So I just want to acknowledge that.
Good. Ali.
Yes, thank you. I just wonder, when it comes to the National Cancer Patient Experience Survey, it says, all right, it says that's the latest one, I assume, 2024. It's something, all right, what sort of emotional support for long-term side effects after treatment cancer patients currently receive? Is there any, I don't know, who's responsible for providing support to cancer patients on the long run to cope with? That's my question, really. Because that must have been covered by this survey, but that's my question.
Yeah, the survey is always a year behind, so by the time we get the results, the next one's underway. It's a bit like the CQC survey in that regard. For George Eliot and Swift, that survey was largely positive and above national average, which is really, really positive. In terms of the cancer support, that can be dependent on what speciality you come under. So all cancer patients come under an MDT, and that MDT, depending on the cancer and the treatment, they've got your specialist nurses. So
in breast, for example, the specialist nurses will be there for you throughout your treatment and afterwards, and you can ring them for support. Sometimes we give people contact information for third parties. So a lot of cancers and conditions, there are third sector charitable organisations who provide really good support, can be on the end of a phone 24/7. And so we signpost patients to those. So it varies really in terms of the different cancers. We do have a lung cancer specialist nurse who's very experienced, so she would be picking up those particular patients at Swift and at George Eliot. Does that help?
Yeah, of course. Thank you. That's great. Yeah.
Anybody got any other questions for Ellie? No? Okay, we move on then to the Quality Governance Assurance Report, and that's got my name attached to it. There's 3 bullet pointed reports for the last 3 meetings. Well, actually, there's been another one since then, but for 3 meetings, pretty self-explanatory. So I think I just want to invite any questions or clarification from these things. Sarah.
Sorry, David, I just wondered if it's worth informally noting that this is now a committee in common with the Quality Governance Committee with George Eliot. So yes, reports will also cover items for George Eliot, not just.
Yes, I think it's fair. Yeah, that's a fair point, Sarah. Yeah, these are. It's obviously an evolving joint committee in common. Inevitably, there are going to be, as you'd expect, issues that are at one trust that aren't at the other, and vice versa. I think it's quite important that as governors of Swift, you're aware that although you're seeing things regarding George Eliot, that isn't something we're inviting comment on. It's actually inviting comment on those that are relevant to Swift. But we're never going to be separating the report out from now on anyway, so it's always going to be a joint report. I mean, sometimes it's quite helpful because you realise there's commonality between issues across the 2 trusts, which is not really that surprising, I suppose, but actually it's quite useful to see. Thank you, Sarah. Any other comments at all on this? No? Happy to move on? See no hands. We can move on. Ravi, Finance Assurance Report.
Yeah, thanks, David. Just I'll take the report as read, but just do a few headlines. So the month 9 reported position for Swift was 2.3 million deficit, and this was compared to our 100k surplus plan. And the main drivers for the variance from plan were we've just come through the winter period, so essentially the operational pressures and the increased demand, which have resulted in additional capacity being open through the winter period. We've been doing quite a lot of work in terms of the financial recovery, and although we aren't quite seeing the reduction in run rate that we were hoping to see, we have still managed to achieve the position through non-recurrent benefits. We continue to work really hard with the divisions to try and ensure that we are meeting our CIP programme. And as we approach year end, there's lots of activity going on with the divisions, just to identify a range of mitigations to make sure that we are absolutely delivering the whole CIP programme and will land our year end position. You will see from the report we are slightly behind on efficiencies, but as I said, we are looking where we're not delivering elements this year, that they will be sustainable cost reductions going forward into the next financial year. We are now in February, approaching March next week. The report is a month 9. We have reported a month 10 position, and that was a 1.4 million deficit. So we are trying to land the position that we get closer to the break-even position for the year. And our focus has now moved on in terms of switching to both in terms of delivering the year-end position, but also switching to the plan submission for next year, which we have submitted a version of a break-even plan. So we'll just continue to work through that. We are having conversations with the commissioners and triangulating our income and expenditure. And I think as we go through the next few weeks into March, we will be expected to submit final plans to NHS England. So take any questions.
Thanks, Ravi. Have you got any questions? No questions, Ravi, it looks like. Okay, so we'll move on then. Audit assurance report, Robert.
Yeah, thank you, Chair. And like your report, it's a bumper crop. There's updates from the meeting of the audit committee held on the 15th of October, the 10th of December, and the 21st of Jan. And there's some common themes running across those. I won't go through all of the reports, but just picking out a few things. So from the October report, we spent some time on the internal audit report that covered the deprivation of liberty safeguards and how well the trust was applying those. And there was some learning that came out of that, because when the trust deprives someone of their liberty under the Mental Health Capacity Act, they are to notify the CQC, and some of those notifications weren't being done for out-of-area patients. So there was some definite things which needed to be tightened up. So we had some oversight of that. We've had a sort of an ongoing set of reports on operational performance in the aseptic suite, and it was pleasing to see that they're working through a lot of those issues. And so you'll find in a subsequent report that we've closed that now because we've had assurance on it. From the meeting, so that was the one in October. The one in December, we were introduced to Jim Boyle. So following the Council of Governors a reappointment of Deloitte as our external auditor, Jim is taking over from Ben Sheriff, who's working on other things within the firm. And that linked nicely to the committee's review of the effectiveness of external audit. And you won't be surprised that the themes that we were examining were fees, a timely completion of the audit, and matters on materiality and complex issues. And not the least of that is how we've accounted for the ground floor of the elective lease. And so that now has been resolved, I think, to everyone's satisfaction. And then and I suppose the other thing to note was we're paying our pharmacy invoices on time, which is good. And then from the 21st of January, looking ahead, the committee wanted to avoid any of the delays that we saw in the completion of the accounts last time. And so there's been some very good dialogue and planning between the external auditors and the in-house team about how that whole process can be made smoother. Okay, so that was just some of the highlights. I wasn't going to go through everything, but happy to take any questions.
Any questions, Robert? No hands raised, Robert. I don't.
Sorry,
think.
Chair. Can I
say something? Yeah.
Yeah. Sorry, there was just a couple of things I wrote down and then failed to say. Just to say that, and this might come up later, but obviously the shape of the committee is changing, and so it will welcome Umar and Phil and Oliver Koffler's ongoing involvement, and to pick up your comment about EPR when we're looking at the 26-27 internal audit plan and our work schedule, we will be spending some time on that. So I just wanted to flag up those points. Thank you.
Okay, we all use lists of paper. I admitted to it earlier, Robert, and I lose them as well sometimes. Can we move on then? Elective Hub report. David Fitzpatrick. It's got your name attached to it.
So I haven't had a chance to make it to Marks and Spencer's or Costa or the Place, but I hope all of you are enjoying it. I think the key point to pick out is about the future. The most important thing about that elective hub is the new wards, and that's actually due to start. The work's due to start this month, supposedly a few days ago. I don't have an update on whether that happened, but the target, which may have to change once all the plans and commissioning and whatnot program is done. The target is mid-March next year for new ward capacity, which I think everybody will be pleased about. I guess there'll be reorganisation and so on elsewhere in hospital, but bottom line is new wards are good for patients. So that's it for this, unless there's any questions.
Thank you, David. A question for David? No, you really must try the Costa. It's actually quite good, actually. Moving on, Ellen Badger, site review, Mike Wells.
Thanks, David. I'll take the report as read. I suppose the hot off the press stuff is that clinical sessions are continuing to increase in number, almost on a weekly basis. The medical unit is now seeing 7 or 8 people every day, which is good. The GPs are, I'm told, imminent for getting in a room with Swift and Swift Clinical Services and the ICB to sign the contract, but there isn't a date yet, so imminent as firm as it gets. And the stuff in the Health and Wellbeing Hub, organised either by ourselves, other groups, or Stour Health and Wellbeing Partnership, just continues to grow as well. So lots of footfall that's increasing.
Anybody got any comments or questions for Mike? No?
Thank you.
Thank you. Thank you. End of life committee, there's nothing to report from Michael, unless Michael wishes to. I have to say I commend Michael because he's currently an inpatient at Swift, and so has the best excuse or the worst excuse, if you like, for not actually being here. So thank you for showing an interest. But can we move on then to the Falls report? David G.
Thank you. Due to clinical pressure, the last Falls group meeting was cancelled, so there's no group report to report. However, most colleges will have read in a recent issue of Pulse where a serious fall was reported, which I decided to look into. The patient in question was resting against the sidebars, which gave way. He fell onto his face, breaking his nose. This brought up several important concerns. The bed was an older one where the sidebars are screw fixed and they had come loose. This is not a problem with newer beds where the sidebars are an integral part of the board, but as the old beds make up about 10% of the total, this is a serious ongoing risk. A safety notice has already been sent out and the problem is on the estate's risk register. This patient only broke his nose, but any further incidents could be more serious, so a more regular inspection of all the older beds is needed, which is something Swift needs to urgently consider. It is not the responsibility of nurses who are busy enough, and I'm sure everyone would agree with that. Thank you.
Thank you, David. Anybody? Oh, I'm getting feedback from somebody. Ellie, do you want to answer to that? Yes.
Thank you. Yeah, thank you for raising that, David. So just to update then, we have external bed company comes in for an annual audit that's been brought forward, so that will be happening in April. That will give us some good idea about our baseline this year, where we are. We have had some new beds delivered in the last week. The EBME are putting in order for further. I think somebody's still on. So that part, and the thing is, before this incident happened, a decision had been made because the beds were being managed between estates and EBME. So for simplicity moving forward, they're all going to be managed under EBME, who will pick up the maintenance moving forward. The audit in April will then give EBME a baseline of where we are in terms of the bed stock, and they can then start moving forward with a programme of replacement and maintenance just with them. The other thing that was a tricky thing, which I'm sure you'll all appreciate, is beds take up a lot of space. So as of April or May, with the reconfigurations, they will now have adequate space in block 56 7, which for those of you know, the site used to be medical records, which will then enable them to have the space to bring the beds in off the corridors and do proper maintenance that way. So that'll be much improved. As David mentioned, we did send out a safety practice notice to all the staff, but we also reiterate with our policies in terms of our safe use of bed rails policy and our medical devices policy, of which a bed technically is a device. All staff are asked to check that a device is functioning and safe, be it a mattress or a pump, before they use it, and if there are any issues, then the staff would remove a patient from that device and report it through, and that is their responsibility to do so. But as I say, we're hoping from the next financial year we're going to have one person overseeing this programme, and therefore it'll be a lot easier to manage. And they will also be, they've started asset tagging all the beds as well from about 2020 onwards, so that's going to really help us know where they all are.
Thanks for that. Any other comments? Any reply to that, David? No?
Yes, if I could. Obviously, I appreciate new beds are very expensive, so it's something which has to be phased, but it's what happens in the meantime that concerns me. I mean, certainly nurses should, it's obviously loose, they should raise it, but they are very, very busy and they are not technically trained to look after this. It's ultimately Swift that is responsible, and knowing there is an ongoing problem for some time forward, that they are the ones that need to up their practice, what they are doing.
Thank you, David. I think, Ellie, you've took all that on board, I'm sure, haven't you? Yes. Yeah. So we move on. Thank you, David. And next is Health and Wellbeing Hub Steering Committee. Carolyn.
Yes, thank you. This is a report from the 9th of February, the last meeting that was held, the previous one having been cancelled because of operational difficulties. Just a couple of points. There's some work going on. Ollie Hisco, Ned, is doing some work with the Surrey Trust, measuring results, which is a very difficult undertaking when you're talking about prevention. So that work is ongoing. And they're also looking for new volunteers, which are not just for the NHS, but for the wider community, although both are obviously welcome. Lillington's been without a coordinator for some time. It's still proceeding as strongly as possible, but it needs promoting a bit more. Then there's a discussion about clinician services at the hubs, and that raises the problem of funding. If you take specialists from the hospital, you have to backfill, or you have to pay specialists to give some clinician advice. I understand that our certain deputy chairman has been instrumental in giving a session, I think, David, which is wonderful. And there was some discussion about whether retired GPs might be interested in doing this. But it's an important. There is a definite ask for it in the hubs.
At that point, of course, I gave my services voluntarily.
Oh no,
I think that's possibly.
Oh, absolutely.
That's possibly the block to many others of my colleagues getting involved.
More respect to you then, David. Much more respect to you. And there needs perhaps to be more promotion of all the services offered. Otherwise, they might fall by the wayside. I took the opportunity of showing you a digest of everything that takes place at each hub. There is a very lovely graphic, which I don't know how to transmit, but if you go into the website, I'm sure you can see, but it shows Shipston, Stratford and Lillington, all the exercises and activities going on there. And there's a protection, there's a provision that only the health and wellbeing team can book rooms, so that the rooms are allocated in the proper and appropriate way. And the next meeting is 11th of May.
David.
Thank you for that, Carolyn. Anybody got any comments or questions? Ian.
I think, sorry, David, I think Michael Coker was just trying to speak. I think it was his voice.
Sorry, yes, because earlier he said his hand didn't work, has it? Michael.
If I may go back to health end of life, I wasn't made an inquiry by the hospital doctor at Nuneaton, who will be in charge of it in future. He was very interested. He spoke to me. I introduced him to the current coroner, who was also interested. They were interested together, so that they have become part, if you like, to somewhat of the consultation for the new theory, for the new series. And I think that's terribly important, because that is an inherent fortune feature. And I thought members ought to know that.
No, thank you ever so much for that, Michael. We will take that on board. Ian.
Yeah, back to the health and wellbeing hubs thing. Thank you, Carolyn, for what you've said. The chaplaincy department this morning had an email from folks who are involved in the new building, the new community centre at the Priory Pools, which is on the Packmoors estate, which is right on the doorstep of the hospital. There isn't a spade in the ground yet, but they've raised some £2.5 million to have this community centre built. And they're trying to lay out now what kind of things they can have in there. And they're asking whether there might be hospital involvement in, you know, the day-to-day working of the community centre. And I just think this health and wellbeing stuff and the stuff that you've listed, Carolyn, at Stratford and Shipston and so on, are the kind of things I would imagine they're interested in having. So I wasn't quite sure who to forward the email to. Who should they contact about this kind of thing going forward for the future? If anybody, I mean, maybe we don't want to be involved, I don't know, but if we do, who would they contact?
Well, the first question is whether we do want to be involved, and I don't think I can answer that question. Maybe Frank Doherty, or Ollie's on the call. Maybe he can help with that question of whom should be informed. Ollie, are you there?
John, you put your hand up. Yes, go on, John.
Yeah, I have to say I've been involved in this project since 1999, when our local MP got me involved then. Chris Elliott is really the lead officer as Chief Exec of Warwick District Council, and the project is well advanced. We've got a lease on the land, we've got planning permission, and the building work is going out to tender within 1 or 2 weeks, and the intention is that there'll be spades in the ground in August. And it's a really exciting thing because it's an area which scores very highly on deprivation indexes, but it sort of generally gets lumped in with other areas which are not so deprived, and so it's a sort of hidden deprivation. But the person who has really the key to getting this moving is Chris Elliott at Warwick District Council. So if you send things to him, it will then get onto the various boards. I'm a member of the project board, but there's a committee that will run the community centre when it opens, which we hope will be in 2027. And the thing that has driven this right from the beginning is health inequalities. And we've taken the view, and I have to say the people who've been running Warwick Hospital over these more than 20 years have always taken the view that the way to deal with illness is to stop people becoming sick in the first place.
Yeah. Thank you, John. That's very helpful. Thank you.
Well said, John. Yeah.
Can I just say before anybody else says anything, I think this email has come from the committee you're talking about, John. So I think they're already thinking through these things and looking now how to get in touch with the hospital and how to go about doing things. Why they've written to the chaplaincy, apart from the fact that I've had some involvement in the past with Priory Pools and through the charity I'm chair of as well, we've given some money. So maybe that's why. But yeah.
Sorry. We had a day last Saturday for stakeholders to come and put their ideas in, and there's a community centre off the top of Spinney Hill called The Gap, which is running exactly as we want to get in the Priory Pool Centre. And Marcus Campos at The Gap has been contracted by Warwick District Council to get this project up and running. So the Gap can easily be found with a Google search of the internet, and Marcus campus is the chief exec there. So I mean, if it goes to Chris Elliott, he will get on to Marcus and vice versa.
Yeah.
Thank you.
Yeah. I would have certainly said Chris Elliott's the man anyway for this. But Adam, did you want to come in on this?
Yeah, just to give some reassurance, Chris Elliott and I have already met and discussed this. We'd be delighted to be involved, I think, both in terms of health and wellbeing activities, but potentially some more of our community activities. And Chris and I have talked about how we could work differently together. Chris is involved in the work in Lillington as well, so is really well versed in how we could work together. So Ian, if you forward me the email, I'll make sure it's picked up.
Will do. Thank you.
Thank goodness there are people who know the answer to that question. Thank you.
It's a team approach, Caroline.
It is
Callie.
indeed.
Callie.
Yes, thank you. Caroline, I just wonder where all the activities are advertised and in respect of the health and wellbeing hubs. Are they advertised on e-polls and any other, I don't know, newspapers, wherever else? How people know about these activities, that's all.
I think that's a work in progress and it's being considered, but I can find out specifically if you like and report back. So unless anybody else knows the answer to that one, where is it being advertised? Certainly there's an initiative to advertise it more widely. I don't know, again, I don't know the answer to that, but like all good solicitors, I know where to find it, so I will look it up. unless Mike or Ollie can answer that question.
Yeah, thank you. That's great. Thank you.
Yeah. Before I bring Mike in, Molly, you got something to, because you were specifically suggested earlier, weren't you?
Yeah, so no, thank you for that. I think Adam's covered the point on the previous point, but in terms of advertisement, Callie, there are a few places. There's quite significant old-fashioned community spaces that we're advertising. There's the website that we have that has the lists of activities. And importantly, I think Kissing It Better do a fantastic job of looking at everything across Warwickshire where people can benefit from the health and wellbeing regardless of the service provider and putting it all in one place. It's a little bit overwhelming when you see it all, but there is a lot there and it is really good. At the last meeting, we did say we need to do better though. So we're hardly resting on this one, and we took an action to look at how we can integrate better with primary care around this. So I'm really glad that you've raised it in this meeting as well, because that sort of gives us confirmation that that's something that needs a bit of work.
Thank you.
Mike Wells.
Yeah, I was just saying, I was talking to Karen Parker on Monday, and she mentioned Priory Pools. So it's on the volunteering team's radar and the Health Wellbeing Hub team.
Yeah. I think Karen Parker's an important name too, isn't she? She's sort of overseeing much of it, or all of it. Yeah. Thank you, Mike.
Okay. And finally, Mike Flaxman. All the mics today.
Sorry about that. I could take it to the South Warwickshire Patient Engagement Forum because all the PPG representatives meet together every 2 months, and it's the sort of thing I like to share with them in the hopes that they'll cascade it into their PPGs and into their practices. So
well, that's interesting, Mike, because I'm on the Clarendon Lodge PPG and we've got a meeting on Tuesday, so I might raise it there as well. Robin Verso is the representative, you know him, and so I could ask him to raise it as well. Would that be helpful?
He's one of the South Warwickshire Patient Engagement Forum leadership team.
I know.
They wouldn't let me join that, but Robin's one of the leadership team, so perhaps it's probably better to do it through him because he can just tell them to circulate it, whereas I have to ask permission.
Okay, I will raise it at the PPG next week, and then he can report.
When
is your joint meeting? Remind me.
Oh,
not before next Tuesday, anyway.
No,
that's all right then.
Yeah.
Okay.
Yeah, compare diaries outside of the meeting, I think. At this point,
who knew this would take so much time?
Such an interesting topic.
19th of March, Carolyn.
Okay, well, the PPG is the 3rd of March. I will write this weekend and ask for
Get Robin to put it on the agenda for circulation. Fantastic.
Sure. Okay, and at that point, we'll move on, I think, to the next. Tim. Medication safety.
Yeah, thank you, David.
this is reporting on our January meeting. The February meeting was cancelled, I think, due to work pressures. Our medication incident rate remains at around target, around 4%. There are a couple of other relevant items. Some trends have been identified with medication errors occurring between wards and ITU, because there are two different prescribing systems in operation in those departments. And most of our community medication incidents relate to insulin use. But given the fact that our district nursing teams are delivering literally thousands of doses of insulin in the community, the rate is extremely low. The most significant incident was we had a 10-fold overdosage incident with a drug, and that related to prescribing knowledge, and that has been addressed. And encouragingly, there's been a reduction of 50% in community device incidents. That's things like syringe driver use in the community, which is good. So those are the key points from that.
Any questions with Tim on this one? See no hands, Tim. Patient Experience Group, not a report. David Fitzpatrick, that's true, is it?
I didn't make any meetings before this report needed to be produced, so okay. I couldn't report anything.
I think that's a very good excuse, David. Very good. Yeah. So he's back with you, Tim. Then I think you're Quality and Safety Board, aren't you?
Yeah, Quality and Safety Board. So we're reporting from the meeting held on the 10th of this month. Key item there is ongoing work to try and align the parameters between Swift and George Eliot, because at the moment the two organisations record things in slightly different ways, so it's rather difficult to compare like with like. That's an ongoing work, not unexpected. We had slightly increased numbers of safety incidents in January this year, but much larger proportion of those were low harm incidents, which probably might well reflect that we're getting better at reporting them rather than there being more incidents. The vast majority of these are made up with basically skin tissue viability problems, medication incidents, and falls. There were 3 severe incidents: one a fall with a fractured neck of femur, one inappropriate transfer of a patient between wards in the middle of the night, and one possible nerve damage incident in ENT procedure. Moving on, there were statistics quoted that I didn't get a drill down into, that we had no longer than an 8-hour ambulance drop-off wait. Seemed an awfully long time to me. I don't know what the average time we have, but that did seem, I know that's the longest, but it did seem rather a long time, and no greater than the 48-hour attendance in the ED.
Yeah, and Ellie's going to help you out, I think, Tim, on that.
Yeah, help me out with those.
That's not saying that we had an 8-hour ambulance wait. So the ICB asked us to report on any ambulance waits over 8 hours and any patients in ED for over 48 hours. And when we say we've had none over 8 hours, doesn't mean we've had one up to 8 hours. It just means we haven't had any that hit the reporting criteria. We don't tend to keep. I mean, I think in January we may have had some ambulances over an hour, but we certainly never got anywhere near that. And then the 48 hours we do report to the ICB. They are usually mental health patients who are awaiting a bed elsewhere and have been escalated through system calls already, so they know about them. So that's what that is. It's a report we have to do through winter for those metrics.
Great.
Thanks for the clarification.
Yeah.
Yeah.
The patient safety newsletter continues. I think that's really excellent. I think that's absolutely fantastic little concise publication for staff. I think that's long may that continue in its present form. I think that's really good. We had one patient safety incident which resulted in an unfortunate patient death. Was a delayed diagnosis of an MI in the A&E department, and the patient had a cardiac arrest and death. This has been looked into in some depth, and it occurred during a time of extreme pressure in the A&E department. And the main learning highlighted in the report was to ensure patients who required an ECG, electrocardiogram, were triaged and prioritised. The ED have since carried out an audit and found significant improvements in how long patients are waiting for their ECG. That's pretty much sums up the Quality Safety Board report.
Thanks very much, Tim. Nobody put their hands up. We move on to Radiation Protection Committee. Paul.
Yes.
Oh, sorry. Before Paul, Kelly's.
Sorry. I just raised my hand. Thank you.
You'd be hopeless at a quiz game, you know, Kelly. You'd never get your finger on the button quick enough.
Indeed.
Go on.
Thank you. Right. All I want to ask Tim is, out of all these severe harm events, does any of these could be categorized as a never event or not? Because I know there's a list of serious harm events that go under this category. Would you know that if anything would go under a never event? That's all. I
doubt it.
Okay, that's okay. I suppose I can look it up, because that is, there's certain categories that go under the never event.
I mean, just as a sort of overview, looking at it as basically having worked as an NHS clinician now for 40 years, given the work and the throughput that goes on through Swift, I'm astounded that there aren't more issues. I think it's quite pretty impressive, to be honest.
Yeah, thank you. Anyway, that's great.
For your minute, Kelly, any never event is always discussed to the Clinical Governance Committee. So
it hasn't been reported. Okay, no worries.
Okay. Paul, Radiation Protection Committee. Where are you?
I'm here. Can you hear me?
All right.
Good. So there was a meeting of the Radiation Protection Committee on the 2nd of February, and this was the first one since August last year. A lot of matters arising was dealt with, and most of the issues have been resolved in the meantime. 2 issues are still outstanding. One is the pregnancy checking audit, and the other is compliance with local rules. The second one, the compliance with local rules audit, is due for completion in May at the latest. And as for pregnancy checking, the upper age limit is now 60 because a patient aged 58 gave birth. There are still some technical problems with display monitors at consultants' homes, and some of the software used for remote monitoring needs updating, and these are still being followed up. In Stratford, the move of the mammography machine has been completed, and there have been no issues associated with mammography, and dosimeters are being returned on time. Radios are now being used to control access to the laboratory to protect any pregnant member of staff going in when they shouldn't. Now, happily, no radiation incidents have been reported, but there have been mistakes involving X-rays, mostly down to referral errors rather than operator errors. If a mistake is made, if an operator error is made, a performance plan can be put into place, and there has been a downward trend in operator errors. They are decreasing. There's been a small issue with the pause and check audit, but that's down to people, if they know they're being watched, they comply with the rules. Downward trend in incidents over the last 6 months, 16 as opposed to 37 in the previous 12 months. Only 2 of the 16 incidents were reportable against 3 in the preceding 12 months. The next RPC meeting is on the 11th of May. That's all there is to it, I have to say.
Thanks very much, Paul.
Thank you.
Any other questions or comments for Paul? No, don't see any, Paul. Thank you for that.
Thank you.
Can we move on? Nothing to report from Safer Discharge Group, I'm led to believe. Two verbals with your name attached to it, Michael Cox. Safer Discharge, Salix Project Board and Wayfaring.
Okay,
Michael.
yes. The Salix Project Board, the Salix project is probably coming to an end in the sense of as it in its current format. And there are discussions currently going on about how this may be picked up in its future, along with other sustainability projects in the overall plan for the trust. So hopefully those discussions will give it some guidance of which way we should monitor for the future for that.
Thank you for that. Any questions on Salix? No. Wayfinding, Michael.
Likewise, the Wayfinding Group has been merged now with the Disability and Equality Access Group, Accessibility. So likewise, that has changed. We also need to review the membership for that perspective from governors, because I think that does need review as to the change, but that will sometimes gets reported in other ways.
Okay, thank you for that. Any comments on that one? No, thank you, Michael. Moving on, General Purposes Committee minutes. Mike, any comments on it?
No, the minutes and the report on the more recent meeting stand as they are really. Just for the public's benefit, this is the meeting that sets the agendas really for all the Council of Governors business in various meetings. And so we will have been the ones who accepted the recommendations from other governors to bring those two assurance items that were obviously heavily engaged with the EPR and the patient and public engagement.
Thank you for that, Mike. Any comments from anybody? No. No, don't see any hands. Patient Care Committee minutes. Jean, anything you want to bring out?
Yes, I don't know, hopefully everybody's read them, but they added value in terms of falls, and I just want to compliment the nurses and the change in the way they organise trying to prevent falls, etc. So where people are at increased risk, they actually leave a nurse present. So on the wards where on Avon ward, for example, where in the past they have had falls, a higher increase than other wards, they've actually kept they've used evidence base, as in who's going to fall likely, and they've kept a nurse in the bay. And I think it's amazing and fantastic that they've actually done that. The community nurse breakdown in skin damage has increased, but the hospital figures have decreased. We've changed, following the review of, as in all governor committees, the comments were that people didn't get a chance to fully discuss issues, and we go through a lot, but we've been able to extend the meeting by half an hour, and they're all happy now. I'm glad to report they can natter on during the meeting. What else? Blah blah blah. Yes, I think that was the main things, really. All the others have been actually reported in the specific discussions on the topics, so there's no point me going over it again. The Safer Discharge, they're every other month now, just like the Patient Care Committee. So I was unable to go to the January meeting, but I know from previous meeting we've actually changed the time of the meeting so that we can fit in with Samara, who was unable to attend before. but she didn't actually attend the last meeting. So hopefully she will attend the next meeting, and we can get her to have some discussions about discharge and TTOs, etc. So yes, it's all going quite well.
Thank you for that. Kelly, you've got a question.
Thanks, Jean. I just wanted to ask, and I know there's always been an issue with TTOs and taking time to discharge patients because their medication is not ready. Is there some sort of target? I don't know. You wait
Well,
the
as
maximum.
quick as possible is the target.
That's the target. It's not like
really, but we need
you
to
aim for
we
an
need to
hour,
try and
2
fit
hours,
in
or
with the blood bikers. We need to
Okay.
try and fit in with the times that they can take them home, or else fit in while the patient's still in the ward and the relatives, etc. I don't know if Ellie wants to add to what I've just said.
No, I think that's fair, Jean. As quick as possible is what we would
Yeah.
like.
Yeah, I mean, it is an issue, but everybody's truly trying and working hard.
trying their best. Yeah.
Yeah, I like the as quickly as possible target. That's very precise, isn't
That's
it?
very precise indeed.
There's some on this committee that would be very uncomfortable with the target of as soon as possible because it doesn't. Anyway, so anyway, I think we better move on at this point.
Very quick question. Sorry, I know it's in the patient care committee minutes or whatever, but I don't know if Tim knows a bit about, because that was something that was discussed at the Quality and Safety Board. It's something, a new policy being written for shared pathways between SWIFT and UHCW. Would you know what sort of pathways these are? Are there for different conditions? What sort of pathways they're looking into? That's all.
They are being redone. I think the main stimulus was the neurosurgical referral pathway.
Oh, okay, right.
Which has been a problem for 50 years.
All right.
Yeah.
Okay.
Which sadly I can confirm that. Yes.
Yeah. Thank
Anyway.
you. That's fine.
Moving on. Sarah, report on resignation appointment of governors.
Thank you. So just to formally note that Manu has resigned as public governor for Warwick District and Borders constituency area. So that does leave us now with 4 vacancies. This report is just for information. Thank you.
Thanks for that, Sarah. And you've got the next one, the annual review of the committee's terms of reference.
Yep, so the proposed amendments are shown as track changes. Each committee have considered the terms of reference and the amendments have been captured in this version. So they're here for the Council of Governors approval and ratification, please. Thank you.
Any comments before I ask? No? So if people are happy to approve, I suggest you keep your hands down. If somebody isn't happy, and they just raise their hand, their virtual hand. No virtual hands raised, Sarah, so duly approved. Code of Conduct for Governors, annual review. That's you again, Sarah.
It is, thank you. So the General Purposes Committee has done an initial review and we're not proposing any amendments to the Governor's Code of Conduct. Governors are required to sign this each year to show that they're signing up to what we've detailed in the code. So it's here for approval and ratification before then circulated to governors to sign for the annual review. Thank you.
The same as before. Any comments? And if you disagree with approving this, raise your virtual hand. No hands raised, so duly approved, Sarah. Thank you. Moving on, Mike. Appointment of shared non-exec directors.
Yeah, quite an interesting item. Too much jollity today, I think. That's not in the Code of Conduct.
It's not in the Code of Conduct either, Mike.
I need to thank Sarah for her detailed drafting of this particular item. I hope it's the last item I'll be putting to the Council of Governors on appointment of non-executive directors in one form or another. But there are 3 items that the Council of Governors is asked to do: consider and approve a couple of things, and receive and support another. Now, these have all been approved already by email by a majority of governors, and I think all I need to do is ask the Council of Governors to endorse that, so that Sarah can formally record the approval in the minutes of this meeting. Happy to answer questions, but hopefully there won't be any.
Anybody not approve? Put their hand up. I think nobody's put their hands up, so I think Julie endorsed. Sorry, endorsed is the term, isn't it? Which to use it. Can use the correct term. Thank you for that.
Thank you all.
So, thank you. I think we're on to any other business. I know of no any other business, but enlighten me if there is. I don't think there is there? Ali.
I just want to ask another question regarding the trust charity, the charitable arm of the charity, and the donations, endowments, whatever people give to the charity. How are they distributed across the trust? I don't know who. Obviously, I know there is a board for the charity, but just to get an idea of that's my question. Really,
Okay,
if anyone knows.
Right, as one of the charity trustees, I'll probably quickly add that there is actually a meeting of charity trustees. I think it's every quarter, and at that meeting, we discuss at length what the resources are within the charity in terms of what legacies or donations have been given, and also about actually how they're distributed. So there is actually, and this is governed by the charity. There's a charity commission actually that defines exactly what the charity trustees should do. Yeah, Ollie's just put in the chat. Like, yeah, where it sprinkles some magic or whatever the term is. I forget now. Ollie's the expert on this, but be assured we follow all the rules that the charity commission actually insist on.
No, that's great. Thank you.
No trouble. John.
Yes, I'm impressed with the way people have been talking about joint working with George Eliot, and clearly it's seen as a positive way forward. And I expect you're aware, well, you know that our outgoing chairman was very keen to improve on the working between the NHS and council's care services. And you'll be aware that the government at the moment are considering changing our councils to merge the district and county council. And there are 2 options: either a single unitary council, which would reflect the joint working of Swift and George Eliot, or splitting Warwickshire into 2, a north and a south, which would seem to be going in the opposite direction to the NHS. And the reason I've raised it here in a public meeting, and maybe members of the public in on this meeting, is there is a short window for the public to express their views. The link to this is on any of the council websites, and people are asked to think which they would prefer: Warwickshire split into 2, a north and a south, or Warwickshire as a single entity.
Thank you for that, John. I'll leave that as for people's thoughts. I think these have been questions from governors rather than any other business. So any other governors want to ask questions? No? We've got a few members of the public here, so I didn't get any written questions, but is there any? Elizabeth, you want to say something or question?
Yes, hello, thanks, David. So I was going to say, when Michael spoke earlier about the wayfinding committee, it's actually called wayfinding and accessibility. It's nothing to do with equality or disability. So you need to know that, because if it was to do with equality and disability, I'd be very worried, really worried. Accessibility has been added onto wayfinding, and I've spoken to some of the officers. I'm a bit unhappy about it, but we're trying to work with it. Tim Crook walked around the elective hub with me. I'm sure he won't mind me saying, because of my concern. I've never been back to Ellen Badger, I just think I need to keep on top of things and watching things for you, because I'm a bit concerned some things are being missed. That's all. I just thought, but the title is Wayfinding and Accessibility.
Yeah, thanks for that intervention, Elizabeth. Your input's always welcome. Michael.
Yeah, I'd just reply to that and say that was my slip of the tongue, but because I think I did say add to it, and I'm pleased that Mr. Dixon has answered that question.
Thank you. Any other questions from members of the public present? No? Thank you for that. So at this point, we'll close the public bit of the meeting. And as the paper says, adjourn to discuss matters of confidential nature. Do people want a comfort break of 2 or 3 minutes before we start, or should we get straight on? Yeah, there's a few thumbs. So it's 3 minutes to 4 now. 5 minutes maximum. So 2 minutes past 4, we'll start, shall we? I'll see you all shortly. Thank you.